All right, so we're going to start our plenary session. I want to thank Faiza and Cynthia for allowing us to do that network session. And I'm glad that you all engaged. I hope that you made some new friends, some new collaborators, caught up with old friends, but used that time to chat and feel part of this community. All right, we're getting the AB working appropriately. Okay, very good. So as is tradition at OHDSI Symposia, we try to make sure that we get through a lot of great science, have plenty of opportunity for collaboration and engagement, and have a little bit of fun along the way. And but usually one of the pieces of feedback we get just about every year is that this OHDSI Symposium was pretty good, but there was this plenary session where we threw way too much information at people way too fast, and it was overwhelming. And usually the feedback is pretty negative, and it's usually directed at me and Martijn. So this year, Martijn and I added Anna to the list of 3 people who are going to throw way too much information at you way too fast and be overwhelming. But I hope that this will be a fun session. Certainly it's on a topic that we think is critically important, and I think we've made some interesting progress that we want to share with you, really with the hope that this becomes a call to action for all of us as a community to work on the problem of case validation. And so this plenary session is going to be broken into 3 segments. I'm going to just try to tee up the problem statement here. Then Anna's going to show some work that we've done on focusing on improving the reliability of case validation. And Martijn's going to talk about how we can potentially increase the scale of case validation. And I hope that coming out of this, folks will be motivated to recognize the problem and think about how we can work together towards some common community solutions. So this work is really continuing our community's journey to reliable evidence. We're here because we believe that we can generate reliable evidence from observational data, and yet we all recognize that there's threats to validity of observational studies. And those biases can take the form of confounding, selection bias, and measurement error. And in previous OHDSI symposiums, we've actually spent an extended time talking about confounding. And at last year's symposium, Martijn presented about best practices for addressing confounding and highlighting the opportunities for diagnostics to tell us about confounding. And we've also published really important work. Ling Ying's work, published in Journal of Biomedical Informatics, focuses on how large-scale propensity score modeling, which is something that we've been advocating for a while, can successfully demonstrate the ability to adjust for confounding, both measured and indirectly measured. So we've made good progress on this space. There's still more work to be done, but we feel like we're starting to get our hands around the confounding problem. Now, we've also spent a lot of time talking about selection bias and making sure that we're sampling the appropriate populations to conduct studies. At the OHDSI 2019 Symposium, George and I talked a lot about legend and how we were trying to replicate those clinical trials, such as the one that George highlighted earlier. And we talked about target trial emulation. Something that Miguel Hernan's been advocating for quite some time, and we too see the value in thinking about appropriate sampling. We've also published in this area for quite some time, including Martijn's paper, a plea to stop using the case control design in retrospective database studies, recognizing that selection bias is a threat that we have to be worried about that we can solve through appropriate design and analysis. But today's conversation is really going to be all focused on measurement error, this third leg to the threats of validities of observational studies, and how we can think about this work. And to do this, I'm going to lean heavily on learning from some of the more recent work that's come out in the broader ecosystem at large. I'm going to start here by looking at the current FDA draft guidance on real-world data. This is a document that our colleagues at the FDA issued in September of 2021. This specific one that I'm going to be focused on here is entitled Real-World Data, Assessing Electronic Health Records and Medical Claims Data to Support Regulatory Decision-Making for Drugs and Biologic Products. And this guidance, while it's specifically a document intended to inform industry about expectations about what the FDA has to do, what FDA is expecting for regulatory submissions. I actually think of regulatory science as really that highest bar that we're all should be aspiring to meet when we think about reliable evidence generation. And so I think we can learn a lot by listening to our colleagues at the FDA about how they're thinking about this problem statement. And in this guideline, there's multiple things that I'd like to read verbatim because I think that the words that the FDA authored in this guidelines are quite helpful. They define what an outcome of interest is. And I'll highlight that they describe that FDA recommends defining an outcome of interest based on the clinical, biological, psychological, and functional concepts of a condition as appropriate. And the conceptual definition for the outcome of interest, also referred to as a case definition, should reflect the medical and scientific understanding of the condition and might vary by study. They also go on in this guidelines to actually talk about the ascertainment of outcomes. And specifically, they describe to identify potential cases in the selected data source and study population, operational definitions using diagnosis and procedure codes, laboratory tests and values, or unstructured data should be developed based on the conceptual definition of the outcome of interest. Now, we have our own jargon here in the OHDSI community, but just to map what the FDA's recommendation is to exactly what we've been saying for several years, we could say in OHDSI speak, you should write a good clinical description up front, and then you should create a fully specified phenotype algorithm that aims to model that clinical description. And so I think that this is a good ethos to just generally be thinking about, that make sure you understand what clinical idea you're going after, build an algorithm that's trying to get to that clinical idea. But what this guideline also does is talks about now how are we going to go about validating it. And the guideline says that the FDA expects validation of the outcome variable to minimize outcome misclassification. And although complete verification of the outcome variable is considered the most rigorous approach, there are scenarios when verifying outcome for every subject might not be feasible, and assessing the performance of the operational definition of the outcome might suffice. Outcome validation involves using a clinically appropriate conceptual outcome definition to determine whether a patient's status, as classified by the operational definition, truly represents the outcome of interest, typically by reviewing clinical details recorded in the patient's medical records in either electronic or paper format. So one of the things I want to reinforce here is that the guideline really suggests there's two alternative use cases when we think about validation. The first is a full case set review, where somehow you figure out how to adjudicate every single person in your entire data set, and then you've got the correct answer post-adjudication. Or the second is that we can figure out a way to estimate measurement error. The guideline goes on to say that the FDA recommends using standardized medical record review processes, including the use of standardized tools, documentation of processes, and training of personnel. A standard and reproducible process is critical for minimizing intra and inter-rater variability, especially for multi-site studies in which medical records usually cannot be shared across systems. In this particular case, I feel like they're preaching to this specific choir, because if you start talking about standardized tools for reproducible evidence, that sounds like a job for OHDSI. And what we're really going to present is how we can think about turning this process of case validation into something that we can actually truly standardize a process with standardized tools. Now, the last thing I want to highlight in this guidance is that the FDA recommends including a quantitative bias analysis in the protocol as a sensitivity analysis to demonstrate whether and how outcome misclassification might affect study results. The protocol should pre-specify the indices, that is sensitivity, specificity, positive predictive value, negative predictive value, that are going to be used in the quantitative bias analysis, and to describe how those selected indices will be measured. And to this, I'll say this sounds good, fully supportive, but there's really left a wide open question, which is how are we actually going to estimate sensitivity, specificity, positive predictive value, negative predictive value, if we're responsible for doing source record verification? Now, just interested, show of hands, how many folks have participated in a study that involved doing case validation through source record verification? Raise your hand. Okay, only a third of y'all. Okay, so for those who raise your hand, actually, can you stand up for just a second? Stand up if you've done a study with source record verification. Okay. All right. And now I want you to wave your hands if you found the experience really super easy. All right. All right, now I want you to jump up and down if you found the process extremely painful. All right. All right, we've seen some jumping going on. Okay. So that stomping up and down is usually how I feel when I get involved in a study that requires source record verification. Not because I don't believe in the spirit of the fact that measurement error is a critical bias to observational studies, but rather that our current processes for how we go about estimating measurement error are extremely resource and time intensive and not necessarily reliable. Now, for general orientation, when I talk about measurement error here, what I'm specifically talking about is imagine that there is some truth, that somebody knows the true disease status of an individual, and that we have some sort of phenotype algorithm that's trying to identify what the disease status may be. And given that our phenotype algorithms are imperfect, that means we're going to have some combination of true positives, true negatives, false positives, and false negatives. And we can use that confusion matrix to estimate these measures, such as positive predictive value, negative predictive value, sensitivity, and specificity. And we're going to use those measures to understand how much error do we have in our measurement, such that we can incorporate it into how reliable is our evidence at large. Now, I want to also commend our FDA colleagues, not just for providing guidance that can actually provide us a path forward, but also for demonstrating good practices. Our friends in CBER published this paper just this year in Vaccine. It's a study that's evaluating adverse events for the COVID mRNA vaccines using self-controlled case series designs. And this paper, I encourage those that are interested in this topic to take a read through this paper. But one of the things that I really want to emphasize is that not only do they have a tremendous public health responsibility to ensure that our COVID vaccines are safe and are doing a diligent job to monitor that, but if you're going to then incorporate medical chart review into that process, we have to figure out how to be able to do that efficiently and scalable so that we can prove safety quickly to communicate out to the broader public. And in this study, they specifically highlight how they went about doing medical chart review, how they created their own clinical descriptions, created phenotypes, then sampled those cases to be able to determine which cases were true positives and not false positives, how they estimated positive predictive value, and how they used that in a quantitative bias analysis. So this isn't just our friends at FDA writing guidelines that everybody else has to follow, but this is also them eating their own dog food and actually trying to follow best practices and actually setting the bar high for reasonable expectations. And what I liked about this paper is that it actually also demonstrated that it's really important to do this. Our colleagues sampled cases for an array of outcomes: myocardial infarction, pulmonary embolism, immune thrombocytopenia, Bell's palsy. And what they identified was some outcomes, such as MI and PE, they actually estimated positive predictive values that are north of 80%, and they were able to evaluate the extent to which there was differential misclassification between those patients exposed to the vaccine and those control intervals. But they also identified that some outcomes, such as immune thrombocytopenia and Bell's palsy, they actually estimated the measurement error to be extremely poor. Their estimate for PPV for immune thrombocytopenia was 4%. It means 96% of the cases were false positives. They estimated Bell's palsy at a PPV of 12%, so 88% of the cases were false positives. If you don't do chart review and you don't know that the information you're looking at is overwhelmingly just false positives, then you don't know that all you're doing is generating noise. So it's extraordinarily important that we actually gain this insight if we're going to actually trust the result of an evidence. And the answer might very well be, there's too much measurement error, I can't trust the study result at all. Which is why we've been harping on this notion that phenotype diagnostics need to be part of our evidence generation process. And sometimes the right answer is to stop and say we can't generate reliable evidence. I also want to highlight a recent paper that came out this year in Pharmacoepidemiology and Drug Safety. It's a commentary written by Steve Lane and Dan Beechler, and it's entitled Validation to Correct for Outcome Misclassification Bias. And I enjoyed this brief commentary because it actually provides an important collection of key points to reinforce what's going on in the community today and where we really need to pivot thinking moving forward. They highlight that indeed regulators are asking for outcome validation to be done, so we got to figure this out. But they also highlight the current way most people are doing validation studies is that they sample from the database, estimate one positive predictive value, and then just report that in their paper. And there's a couple problems with that. First, as they highlight, just knowing a single PPV value actually doesn't tell you the magnitude of the error that the study is going to have. So basically, all you learn is that your outcome is incomplete, and then you go on your way. Worse yet, you now have an estimate that you know could or could not be biased, and you don't do anything about it. And so what Steve and Dan do in this paper is they highlight the need for our community to figure out how to estimate measurement error more appropriately. And specifically, they contrast the conventional validation approach, which is just sample out of your outcome, estimate a PPV, and hope for the best, to this approach that they describe as validation to support bias analysis. Namely, they describe that you shouldn't just have one phenotype algorithm, you should also create a cohort that's an extremely sensitive screening algorithm. And on the basis of that, you can sample from that population and now have the potential ability to estimate both PPV and sensitivity. Now, I know the words are super small on the screen. I encourage you to read Steve and Dan's paper on this, but I'm going to provide a cartoon depiction of the gist of the idea that they're highlighting. Effectively, you start with your phenotype algorithm, and indeed, you can estimate positive predictive value by sampling out of that cohort and estimating positive predictive value as the proportion of the cases that you sample that turn out to be true cases. And that one measure could be quite helpful. What they suggest is that a highly sensitive screening algorithm, something that subsumes your primary algorithm, can be used as another sampling frame. And if we sample from this highly sensitive screening algorithm, then we can estimate sensitivity as the percent of people you found in your highly sensitive screening algorithm that happen to belong to your primary algorithm. What they also state very importantly is we have to be worried about differential misclassification, just like our friends at CBER did to look at exposed and unexposed time. And so what that means is if you're going to do this right, you need to actually sample not just from your overall population, but you need to stratify your sample to talk about the target population and your comparator population. And so that means you need 4 cohorts that you're going to sample from. All totally fair and reasonable and good. There's just one consequence to this, which is now you need to sample and validate from 4 different populations. For all of you who stood up and are jumping up and down, I can imagine the cringe that you're feeling to say, great, good suggestion. You just made my work at least 4 times more effort than where I was before. Yes. Now, I want to highlight in our community that we've been thinking about this problem of estimating measurement error for quite some time as well. I want to specifically shout out the work that Joel Swerdell has been leading in our community. Joel introduced a couple years ago the idea of phi-valuator. And for those of you who are not aware, phi-valuator is, this is a paper that was published in Journal of Biomedical Informatics a couple years back. But basically the idea was to create a probabilistic reference standard based on noisy labels that use that same idea of a highly sensitive screening algorithm, but combined it together with a highly specific cohort. Use that to train a machine learning algorithm that would estimate predicted probabilities, and then use that to estimate measurement error for those exact same metrics, PPV, sensitivity, specificity. Now, Joel's been making great progress on this. Last year, published phi-valuator 2.0, which did 2 important things. One is improve the algorithm itself, but second, provided a benchmark data set so that all of you could actually think about the problem of measurement error also, develop new approaches, and measure how well you can measure measurement error. Think about that for a second. So this is an important paper that came out last year that I encourage you to take a look at. But I'll also shout out that over there, Joel's got a poster. And this year, one of the things that he's highlighting is the very real threat of differential misclassification. The idea that you can't just assume that an estimate is going to apply equally across your populations, but that rather, if we're going to think about measurement error, we now need to be worried that measurement error may not be a constant. And this is going to be important, and it's the reason why, for example, Steve and Dan were arguing we need to stratify by exposure status, because we shouldn't be making assumptions about that it's okay to have non-differential error. I want to highlight one more paper that was published a couple of years back, but I think given that OHDSI is a multidisciplinary community, we've got folks here that are more on the informatics side, folks here that are more on the epidemiology side. I really like this paper because they specifically said, I'm trying to write a paper that connects epidemiology and informatics speak together. And this paper by Newcomer et al. Is entitled A Primer to Quantitative Bias Analysis with Positive Predictive Values in Research Using Electronic Health Record Data, published in JAMIA. And what's really nice about this paper is this example that I'd want to take a minute to talk through. What they did was they took an observed estimate, an estimate you'd find in any reasonable paper, which is a relative risk of 0.87 with a confidence interval 0.76 to 0.99, which means that there's a statistically significant decreased effect. They also have a positive predictive value estimate, as we would see reported in any paper, of about 93%. Now, what they showed was, depending on how much differential misclassification you observed, that answer of 0.87 could either be the true answer, if we don't actually have any differential misclassification. It could be that the true answer is a larger effect if there is differential misclassification, or it could be that there's actually no effect at all. So this is why when Steve and Dan said, let's get away from just estimating one PPV and reporting it and hoping that it's good, this is actually the mathematical proof of why we all have to get away from that. Because having a PPV by itself and a study estimate, you don't know whether you can actually trust that estimate, whether it's right on the high side or whether it's wrong on the high side or wrong on the low side. You don't know unless you actually figure out a way to estimate measurement error and consider the potential for differential misclassification. So, with that, I want to highlight how we can think about incorporating case validation into our evidence generation workflow. And I'm going to highlight three scenarios really predicated on the work of the FDA guidelines and what I've talked about so far. So first I want to highlight that what we've done really, really well in the OHDSI community is we've been taking this journey from data to evidence, and we've been developing standardized processes. So now we should be very proud that we can go from a database standardized to the common data model. We can extract cohorts following our best practices for phenotype development and evaluation, and we can perform very rigorous analyses, and we can do that very efficiently now. You know, it's no longer the case that this process is a journey that needs to take years. We can demonstrate that this can be done efficiently in a matter of days. And effectively, I'll oversimplify it to say that all of our analyses for population level effect estimation effectively come down to creating some sort of 2x2 table where you've got target and comparator, you've got outcome and not outcome, and we're counting up how many times we see these events in these cohorts. Now, this process, because we've gotten really good at producing the effect estimate off of this 2x2 table, this means like we can generate evidence, but this pipeline doesn't have our incorporating measurement error into that process. So what would it look like? Well, if we were to follow that first use case from the FDA guidance, which is full case set review, what that means is even though we can be really efficient to generate evidence and produce an effect estimate, we then need to go back to the drawing board for every case in every patient, whether they were exposed or not, whether they have the outcome or not. We need to go pull all of the source records for all of those patients. We then need to figure out some sort of process where some human reviewer is going to read all of those source records for all of those cases, determine whether those cases are real, yes or no, provide some rationale. And then what we're going to do is we're going to correct the false positives and the false negatives, effectively restate our data set so that we can rerun our analysis and produce an answer. Now, there's nothing wrong with this as an objective that we may have to do full case set review. The simple logistical challenge that all of you that stood and jumped up can fully appreciate is that it's super hard to do a small subsample case review. So imagining doing something where we've got tens of thousands of exposures and trying to do case review of every single one of those, probably to many of you seems like completely outside of the realm of the possible. Now, that conventional validation approach that Steve Lane and Dan Beechler were kind of arguing against kind of looks something like this. Instead of taking the full data set, let's just do a sample, but let's specifically sample out of the outcome set. So we'll only sample our cases. We'll then get the source records from the electronic health record data. We'll figure out how to get some sort of expert clinicians to review that and say whether those cases are yes or no. and will produce a positive predictive value. But as we've highlighted, getting this single positive predictive value doesn't connect back to the answer. All you're now left with is two totally different artifacts, an effect estimate and a PPV, and you haven't learned anything about whether or not you can actually trust the answer you provided. So as Steve and Dan are arguing, and I'll argue too, we need to really get away from this because we're not helping the situation when we follow this framework. The question is, how do we actually do what the FDA recommends, which is to estimate measurement error to enable quantitative bias analysis? And the general workflow would look something like this. Maybe we can figure out a way to sample from not just the outcomes, but from the entire data set. At that point, we can determine whether or not we need the source record data for that sample. We have humans review the process. Those answers from that adjudication will allow us to estimate positive predictive value and sensitivity. And on the basis of those, quantitative bias analysis, as Tim Lash and colleagues have published numerous papers, provide us extremely straightforward ways to calibrate the effect estimate conditioned on the measurement error that you've now estimated. Now, this workflow, at least, is theoretically possible. The question is, how reliable is this process and how scalable is this process? And given that many of you have gone through the conventional process and found it to be extremely painful, I'm going to guess that many of you are cringing at the possibility that this becomes your new paradigm. And so what Anna and Martijn are going to present is some thoughts about how we can make this process be a little bit more reliable and maybe a little bit more scalable. But to do that, I need all of you to be thinking about the process of being case adjudicators. So to do that, I want you to be thinking about the clinical disease of end-stage renal disease. I'm going to provide you a very brief synopsis of our clinical description. For those of you who are not familiar, end-stage renal disease, it's a terminal illness. It can be measured based on a GFR value less than 15, but this is the fifth and final stage of chronic kidney disease. Oftentimes, patients with ESRD will be caused by diabetic nephropathy, but we also see that it can have origins from other etiologies. Patients may show up, present with nausea, vomiting, and other types of illnesses, but as soon as someone's identified as potentially a patient with end-stage renal disease, they need to be actively monitored to monitor their kidney function, to manage the disease progression, and ultimately this could result in requirement for dialysis or a renal transplant. So end-stage renal disease is a clinical idea. Show of hands, how many folks are familiar with end-stage renal disease as a target? Okay, like a third of you. So, okay. So I'm going to ask everybody to participate in this effort, but if you're not as familiar with the clinical idea, I'll give you a pass. But what I want you to do is, given this clinical idea, let's adjudicate some cases. So I'm going to ask you all to pull up your phones or your laptop if you want it. I want you to go to pollev.com/Patrick Ryan. And I'm going to read you a case narrative. I'm going to ask you a simple question, yes or no, is this a case? I'll give you guys a second to take a scan of that, and it'll be on the next slide too. So just pollev.com/Patrick Ryan 800. We're going to do a case adjudication. So here we go. Here's our case. Got a 50-year-old male with a history of type 2 diabetes, hypertension, and chronic kidney disease due to type 2 diabetes. He presented for a pharmacy visit followed by an outpatient visit. During that visit, he was diagnosed with chronic kidney disease stage 5, end-stage renal disease, and other related complications. Prior to the visit, he was diagnosed with chronic kidney disease, anemia, and vitamin D deficiency. And after that visit, he was diagnosed again with end-stage renal disease, anemia, hyperlipidemia, and hyperparathyroidism due to renal insufficiency. And he was prescribed calcitriol for 54 days. So my question for you is based on this clinical narrative, is this a case? I ask that you vote now, yes or no. All right, I'm seeing how many of you are voting. Doing good. I'm glad that half the room is engaged. The other half are just probably usually bored to tears by my talks usually, but we're doing pretty good. I'm always fishing for compliments. Thank you, Marie. Very good. All right. Popcorn in the microwave is slowing down a little bit, but we've got about 2/3 of y'all have voted on this particular case, so thank you for that. Now, your job's not done. I want you to adjudicate another case. Hypothetical clinical narrative number 2. It's an 80-year-old female patient. She had an outpatient visit followed by a laboratory visit. The primary diagnosis during the visit was acute renal failure syndrome, while the secondary diagnosis included chronic kidney disease due to hypertension, chronic kidney disease stage 2, essential hypertension, hyperlipidemia, hypothyroidism, proteinuria, renal disorder due to type 2 diabetes, renal function tests abnormal, and type 2 diabetes without complication. Now, prior to the visit, the patient had been diagnosed with hyperlipidemia and hypothyroidism. No treatments were recorded prior to the visit. Lab tests conducted during the visit showed abnormal levels of creatinine, but the GFR was normal. The patient's urine creatinine level was also normal. And after the visit, the patient continued to be diagnosed with hyperlipidemia and hypothyroidism, but there was no evidence of end-stage renal disease. So your question, please vote now, is this a case of end-stage renal disease? All right, I see you guys voting. Good. That's not beer yet. All right, slowing down a little bit. Very good. I'm glad that you guys are participating. This will make this fun. Very. All right, all right, that's a good number. So, okay, you're not done. Last case, I promise. I want you to flip it over to the next one. Got one more case to read you. This patient's a 90-year-old female who had an emergency room visit and an 8-day inpatient stay. She had a history of chronic kidney disease, hypertension, osteoporosis, and other comorbidities. During her visit, she was diagnosed with chronic kidney disease stage 4 and stage 5 due to hypertension. She also had a history of chronic kidney disease stage 2, 3, and 4, as well as malignant hypertensive chronic kidney disease. The patient was treated with furosemide and calcitriol during and after her visit. So my question for you, is this a case of end-stage renal disease? Vote now. All right. Well, we're going to leave that poll open, at least on that third one, if you guys are deliberating maybe on that. But what I'm going to do is I'm actually going to turn it over to Anna. So now that you've all thought about what it's like to adjudicate a case based on a clinical narrative, I have Anna talk to you a little bit about some of the amazing work that she has led that should give us a path forward to thinking about how case validation may be able to be a little bit more reliable.
So Patrick talked about these guidelines for source record review, and now you guys also reviewed some of the source records. But for those who are not familiar with this process, I want to just tell you about my experience. So as a student in Columbia University, I was doing source record review in the form of chart review in EPIC. And this is the snapshots of all sorts of things, which looks like a big blob of, big messy blob for a test patient, of course. And what it shows is that every time when I wanted to answer a simple question of whether a patient has a disease, I had to go through all sorts of things: multiple providers' notes, imaging data, pathology data, lab measurements, sometimes even PDFs from the scanned written notes from 10 years ago. And this is really hard and time-consuming. And for this purpose, for the purposes source record validation, structured data is oftentimes thought of unusable because many people think that there is data loss from charts to structured data. What this slide shows you is the patient profile in Atlas for a person, and gray dots represent all of the events in their history in OMOP CDM. And this picture shows only 3 years of their history, yet you can see that there are more than a lot of points, in fact, more than 10,000 data points. So again, if you're using structured data, you have to sift through all of this information, identify the relevant elements, and discard all of the noise. And from this perspective, the main challenge of case review or chart review or source record validation is not that we have too little data, is that we have too much data. And with that in mind, we developed, implemented, and tested a solution which we called Keeper. Of course, we gotta find a very nice acronym for it. Here we didn't do such a great job, we are missing letters, but knowledge-enhanced electronic profile review system. And this work has been published in JAMIA, and luckily for us, it went live a couple of days ago, so now you can check out the QR code, get more information, and the subsequent slides will be based on this experiment. And first, I want to tell you about the key principles we identified, because we really thought hard about what can be a chart review alternative, and we identified these three principles. We think that for this solution to be interpretable, we need to follow general clinical reasoning principles, something that a doctor does in their clinical practice. We also want the solution to be scalable, which means that we really need to standardize both the input, OMOP CDM, and the output so that we can use this solution for any disease across any data source. And third, because we said that volume of the data is such a big problem, the output of such a tool or application has to be limited to only relevant elements. And let's first think more about the clinical reasoning principles for those who are not that familiar with this concept. What we really think about here is to follow the steps a regular doctor takes to diagnose a patient in their practice. So what they do is patient shows up with some sort of complaints and symptoms, and doctor evaluates those symptoms and complaints. Then they ask the patient for their disease history, for their previous conditions, comorbidities, risk factors. And what they're trying to get at is to confirm this preliminary diagnosis and discard all of the alternative or differential diagnosis. And to confirm the diagnosis, we usually run lab tests or other diagnostic procedures. And if a condition is confirmed, then we follow up with treatment and follow-up care. And these conceptual elements served as the base for Keeper. And Keeper is now an OHDSI package, open source R package, available on the OHDSI GitHub page. And what it does is it takes a cohort of patients you created. We're gonna use end-stage renal disease again as an example. It also takes from you the list of concept IDs to identify those relevant elements for each category. For example, if we think about symptoms, you would input for end-stage renal disease, you would input concept IDs for vomiting, shortness of breath, edema, and so on and so forth. And using these two inputs, Keeper extracts the data from OMOP CDM within relevant time windows. For example, for symptoms, we extract these concept IDs from the patient data within a month prior to the cohort start date. And at the end, what it outputs is the data frame or table, which you can, of course, save and look up in Excel, which has rows per patients and columns per these clinical categories. And here you can see the example of the output for the symptom column. But also, let's take a look at the overall output of the Keeper. This slide shows you all of the columns that you have per patient, and then example for one patient with suspected end-stage renal disease. And the orange boxes show what I wanted to highlight, which is the presentation where we see that this patient was presented with chronic kidney disease stage 5, and progression of the disease where we see that they had multiple occurrences of code of end-stage renal disease and CKD stage 5 after that index date. So based on this information and other elements, I would say that I think this person is a case they really have end-stage renal disease. And this is how you produce and you use this tool. So of course, we wanted to evaluate whether it works at all. And this is the overview of the experiment, which you don't have to really read and spend too much time on, because we will take each of the steps of the experiment and go into more details on that. The very first thing was to prepare the data, and we selected 4 conditions to make sure that we tested on all sorts of different diseases that act differently, that require different care, to really make sure that the solution is generalizable. And we picked acute appendicitis, type 1 diabetes, acute appendicitis, chronic obstructive pulmonary disease, and end-stage renal disease. For each condition, we selected eMERGE phenotype, executed it, sampled 20 patients randomly out of cohorts, and created the gold or reference standard by having 2 clinicians iteratively review the full charts and all of the structured data for each patient until disagreement is resolved, which is considered to be the best practice right now. Separately, we created keeper profiles for all of these 80 patients. And by the way, the table shows the distribution of cases and controls for gold standard. So we created the keeper profiles for these 80 patients and executed them on Columbia University Electronic Health Records, which is a very rich EHR system. And here you can see the inputs that we provided for each of the conditions. The individual elements are not really material. What I want to show here is that we were able to consistently apply this pipeline framework approach to all of these conditions, even though they're very different. And you can see that some of these cells for the inputs into Keeper are empty because you do not necessarily need all of the data elements, but the Keeper still can perform consistently well for different conditions. And using these Keeper profiles and gold standard, we executed the actual experiment. We asked 4 independent clinicians to review both Keeper profiles and do the manual chart review. And we did it in 2 rounds, and also we used 2 different sequences. They first reviewed Keeper, then chart, and first chart, then Keeper. That was done to make sure that we minimize bias, that there is no carryover effect, and that we really get the results that we can trust. And at the end, the data set was 160 adjudicated or classified patients using Keeper and 160 patients that clinicians classified using chart review. We collected a couple of metrics. First, we wanted to look whether this approach is efficient, because we said that time consumption in chart review is very high, so we wanted to look whether it's going to be any better. So we measured the time to review. We also wanted to look at all sorts of flavors of agreement. We wanted to examine whether these 2 approaches agree with our reference standard. We also wanted to look whether Keeper and charts agree. And finally, we wanted to examine consistency of review, or whether different reviewers can arrive at the same conclusion. And when we looked at the time, we observed statistically significant difference in the time needed to review Keeper profiles versus charts. And Keeper, in fact, was twice as fast, and this trend of Keeper being faster was observed consistently for all clinicians, for all rounds, for all conditions with a different magnitude. And this opens up a new opportunity of reviewing more cases, which goes back to what Patrick was talking about the paradigm shift. Now, all of a sudden, we can do it slightly faster, so we can do more. And the second big bucket that we examined was agreement. So I want to just provide you more details on what we mean by agreement. Here, we will focus on agreement being the proportion of cases for which both reviewers said either yes, it's a case, or no, it's control. And this small table provides you a nice illustration of how it's actually computed. It's a very basic computation. Here we can see that the first 7 rows, both reviewers said yes, it's a case, and then for the bottom 5, both of them said it's a no. So It's 12 cases they agreed, divided by 20 cases total. We have the agreement of 60%. We did computed kappa statistics in the paper, so if you're interested in that, please check it out. And the first type of agreement we wanted to look at is, of course, the agreement with the gold standard or accuracy. And what we discovered is that keeper tend to agree with our gold standard as much as the chart review. And you can see the proportion of agreement here. It's 88% versus 86.9%. The difference was not significant, but keeper was non-inferior to chart review in that regard. We also wanted to look at whether chart review and keeper agree. And we will use this picture a lot, so I want to pause here and make sure that I orient you in this picture. So this matrix represents all of the permutations of different reviewers and different methods. And if you look at the box highlighted in orange, this number, 91, is the percentage of the agreement between the reviewer 1 when they used keeper and reviewer 1 when they used chart. So that represents the agreement. That means that in 91% of the cases, that reviewer arrived at the same conclusions when using charts and when using keeper. And when we account for the second reviewer, the overall agreement between charts and keeper was from 48 to 91%, which is almost perfect agreement. Pretty much whatever is, everything that is above 80% is considered to be very good agreement. And if you look at these numbers across conditions, we will see that the agreement between keeper and chart was consistently high across all conditions, and it never went below 75%, which is really important because here again, we wanted to build a solution that is not disease-specific, but that is disease-agnostic and can be used for all diseases. We also wanted to look at the agreement among reviewers because consistency of review is a very important parameter as indicated by FDA, which Patrick highlighted in his talk. So when we look at the agreement of reviewer 2 using keeper and reviewer 1 using keeper in orange box, we see that in 91% of the cases, their adjudication, their classification was the same. While in charts, it was only 76%. So here we do observe a statistically significant difference in consistencies of reviews. And keeper enabled us to perform more consistent reviews where different reviewers agree with each other more, which is a truly fascinating finding for us. And as we look at the same picture across diseases, we observed that there yet again was some heterogeneity in agreement between reviewers, but nevertheless across the board, keeper performed better in that regard than charts. And another interesting thing here, you see yellow boxes that represent poor agreement. For end-stage renal disease, we saw that there was poor agreement based on charts. So this is pretty interesting. Like, how come that people arrive at the different conclusions about these same patients when using charts? Well, and this is where we also performed an additional analysis of those discrepancies in charts versus keeper. And there were two main problems with charts that we identified in this experiment. First is information interpretation, because people went through the narratives written by other clinicians, and then they tended to trust these narratives, even though there might have been not enough objective support for these conclusions, in which case the agreement was lower. Another source of discrepancies was, yet again, high chart volume, because sometimes you had to dig really deep into the charts, while keeper just readily presented you this information. And then finally, even though the performance for Keeper was good, still missing data was a problem for some individual cases, and we have to acknowledge that. That concluded our first experiment published in JAMA paper, and this is a natural extension of this experiment where we wanted to test whether our approach will perform the same when using another data source, claims data source, and with other clinicians, with other reviewers. So here we used the same 4 conditions. We sampled 100 patients total, and we asked 5 reviewers to review Keeper profiles for all of these cases. We computed the agreement among reviewers, and that was all done, as I said, on the claims data source. And now, all of a sudden, we see a matrix that is more complex because now we don't have 2 reviewers, we have 5 reviewers. And this is pretty unique on its own because a common practice is to have at the very maximum 2 reviewers. So the fact that we had 5 opened up an interesting opportunity to analyze this data because it's not commonly done. And what you can see here is that the agreement varied from 72% among each pairwise comparison of 2 reviewers to 91%. And there were no obvious outliers in these pairs, and the agreement was good or almost perfect across the board. If we look at the conditions, now we do observe more heterogeneity, where for type 1 diabetes, all the reviewers agreed extremely well, but for appendicitis and end-stage renal disease, maybe they agreed not that well, sometimes. So let's actually think about it. What these 5 reviewers and their adjudication look like on the data level. This is the data frame that we essentially produced as the result of this experiment. And you have 5 reviewers that we had and 20 cases which they adjudicated for one condition. At the top, you can see that there are cases for which all of them said yes. In the bottom, all of these reviewers said that these are controls and not cases. But now there is a big bucket of things in the middle where at least one reviewer disagreed with the other reviewers. And what it highlights is that the more reviewers that you have, naturally you will get more heterogeneity. And this finding is underappreciated because, yet again, in a common regular study, you cannot even observe that because you only have 2 reviewers. Now, when we looked at these cases, what about your cases? Let's look at what you said about those results. So first of all, what I wanted to say is that this narrative looks very much like what you would read in patient notes. Like somebody, a clinician, would write these paragraphs about this patient. But in fact, these narratives were written not off of charts, but off of the output of Keeper. And in fact, off of the output of Keeper that we used in our experiment as well. So for the first case, 79% of you said that it was a case. So that was, the majority of you thought that, well, yeah, of course, this patient has end-stage renal disease. Then for the second case, 85% of you said that it's not a case, it's a control. So that's, again, the vast majority of you. And now finally, and response. And then finally here, we do not see that much agreement because 69% of you said that it's a case, and then a third of you said, well, I actually don't know, I think it's a control. And as I already revealed, these cases do correspond to the actual cases that we reviewed as well. So naturally, the first case is the case where all of our reviewers said yes, similarly how you guys did. The second case, where 85% of you said it's a no, all of our reviewers said it's not a case. And then for the last one, where a third of you said it's a no, we see a pretty much similar distribution. Like reviewers were confused. Some of them thought it's not a case, some of them thought it's a case. So first of all, that means you can do, all of you can do now charge review, case adjudication, you're fully equipped. And second of all, that highlights that this problem is really hard. And sometimes you have heterogeneity and you're confused not because of what you miss, but because of the conflicting information that you have in your data. And going back to this workflow presented by Patrick, what we just showed is that we can improve this workflow by replacing source record by keeper output. And now Martijn will talk about other advancements that we can introduce.
Thank you, Anna. All right, yeah, let's go and talk about how we can scale this up even further. And let's start with taking another look at the generalizability of keeper performance. So Anna already talked about 2 experiments that we did, both of them using the same set of 4 diseases, but using different types of data. And these diseases were actually selected more with a little bit of an idea that they would be more amenable to a system like Keeper, with clear expectations of health utilization and therefore clear markers to use in the data to classify disease status. And also the cases, I believe, were not fully sampled from a single cohort, so you couldn't actually use them to estimate PPV. So we thought, let's set up a new experiment, a third experiment. And so we did. This new experiment, we selected 6 conditions representing a range of complexity. So some of these we actually were expecting to be much harder to do case validation on. So the 6 conditions were acute bronchitis, hyperlipidemia, hypoparathyroidism, osteoporosis, rheumatoid arthritis, and viral hepatitis A. Now we actually included a whopping 7 reviewers to review this. Each of them reviewed 25 patients per disease, so that's 150 patients total times 7, so that's a lot of case validation. And the metrics that I'll be talking about is, well, first and foremost, just like Anna was doing, agreement among reviewers, but also now we'll be able to actually compute positive predictive value because we took a full random sample of these cases. Database, again, the Optum Informatics claims database. As Patrick mentioned, best practice is that we should have clinical descriptions for each of these diseases, as well as phenotype algorithms. So here we show that we actually did have those. Once you get the slides, you will be able to click on these links and actually explore all these artifacts. And also, as Anna explained, if you want to use Keeper, you actually have to configure it for the disease. So for every one of the Keeper categories on the left, you have to pick sets of concepts for each disease. So I'm just showing you here that that's what we did. That was also quite some work. And again, you see that not all of the categories are filled for every disease. So it doesn't always make sense to have concepts in every category. So jumping right into the results, here I'm showing you the agreement between all 7 reviewers. And what you'll notice here is, and actually what surprised me, is that the overall agreement is rather consistent between reviewers. It's not that they agree a lot, it's that they all tend to disagree pretty much at the same level. Agreement was somewhere between 66 and 79%. And those results are in line, but a little bit lower than what Anna showed you, where the agreement was between 72% and 91%. But as I said, this was actually what we were expecting because we had picked harder diseases. And there is an auto forward on this. All right, we can actually stratify this by disease, and here you actually see that some of these diseases really are harder to agree on than others. Hyperlipidemia and rheumatoid arthritis had strong agreement across all reviewers, with some even having 100% agreement. I'm sorry, the auto forward keeps going. Hepatitis A and bronchitis actually had very little agreement among reviewers. And just to highlight that last one, hepatitis A, that one was just hard because in this claims database, we didn't have the results of the tests that were performed. You just knew that tests were performed, and oftentimes there are actually multiple tests performed, and not a lot of additional information that could make you decide whether or not they had this specific type of viral infection. So that just made it really hard, and as you can see, the reviewers disagreed a lot. All right, so the year is 2023, so I'm wondering how many of you know which direction this is now going. But one thing that I didn't mention is that not all of these reviewers are human. And the question now to you is, well, which one of these reviewers do you think is not human? And I hope the auto forward doesn't take me to the next slide. So please vote now and think real hard, which of these reviewers do you think is actually not a human reviewer? I'm going to go quickly back and forward just so I don't auto forward to the next slide. All right, let me actually just flip to this thing. And switch to instructions. Yes. All right, already 66 people have, well, let me go back to the slides so you can take another look. Good to go back and forth. What do you all think? Who is not the human?
Less people seem to want to vote on this.
Yeah, we have 100 people now. Oh, more coming in, all right. Yeah. Yeah. Or the previous slide. Who is the odd one out? All right, I'm not going to keep you in suspense much longer. Let's look at the results. All right, so the majority vote is reviewer number 4, with some additional votes for 3, 6, and 7. All right, I'm not going to keep you in suspense much longer. In fact, reviewers 1 through 5 are humans, and reviewers 6 and 7 are large language models. All right, I'll explain the names later. So yeah, we all know about large language models, of course. I'm not going to use the word artificial intelligence here just because I think that unnecessarily makes things more mysterious than they really are. So I'm going to use the word large language models, and I'm trying, you all know what they are, but I want to just have a basic explanation of what these actually are. So a large language model is a neural network. If you're from my generation, if you're a younger generation, you would probably call it a deep learning model, which means that it consists of layers of nodes with weighted edges between them. And on one end, you have the input going in, and the other one, you have the output going out. Each node, the output of that node is computed as taking the output of the previous layer, all of the nodes there, which could actually be just the input, multiplying each of those outputs with a weight, and every edge has its own unique weight. Once you've done that, you sum across all of those, and you apply some activation function, like the one I'm showing you here in the bottom right. And now you have your output of that node, and you keep on doing that and then that until you reach the output. Now, of course, the trick is getting the weights to be the ones you need. And so you need to train this model. So you start giving it some inputs and having the network compute an output, which at first will be complete rubbish because the weights are random at start. And then you compare what you produced as an output to what you wanted it to be the output. And then you carefully nudge all of the weights in the model in a direction that would get it closer to the result that you wanted, through a process known as backpropagation. And by doing this really lots of times, you can basically have such a model learn almost any type of relationship between input and output. It's that simple. You're modifying these weights until the model does what the training data basically tells it to do. So I know this is probably a rather gross simplification. I probably have some people rolling their eyes at me right now, but I think this is enough to make the main point. Now we apply these models, what makes them large language models is by applying them, of course, to language. And we have this first phase that is called pre-training, where the model is used to predict the next word in a text. So here I have a text from Alice in Wonderland, where Alice is asking the Cheshire Cat for directions. And we just took a part of that text and just are asking the model to predict the next word. The nice way of setting the problem up like that is it's very easy to create a massive training set because all you need is just large numbers of text. Just basically, you can scrounge the internet for anything that you could put into this model and turn it into a training set like this. And even though this is probably not as hard for us humans to do, this is actually a really hard problem for a machine. Because to know what the next word is, and to be really good at this job, you need not only to understand things about grammar, so you need to know that the next word is probably a proper noun, you also need to know something about semantics. For example, the next word is somebody who actually says something, and not everything can speak, although in Wonderland apparently cats at least can. And lastly, you need to understand the context in which all of this is happening. So in this case, it's a conversation between the cat and Alice. And only when you grasp all of those things can you actually predict that the next word is probably Alice. Just to make the point that by having the model train on this, it actually needs to build a quite large understanding of the world as a whole. Now, this idea is not new, but the reason why we're all of a sudden now seeing very spectacular results is primarily the scale at which we're doing this. So I'm later going to be talking about two models, GPT 3.5 and Llama 2. And those have 165 billion and 70 billion parameters inside them. So these are the weights that are need to be adjusted. So those are massive models. The corpus size that are trained on 30 billion tokens, where a token is roughly 3/4 of a word, or a whopping 2 trillion tokens for Llama 2. And the time to train these models is also quite big. GPT 3.5 used estimated 355 GPU years, which means if you had a single GPU, it would take you 355 years to train GPT 3.5. Or if you have 355 GPUs, it would roughly take you a year. And Llama 2 is in a similar ballpark. Now, once you're done with the pre-training, now you have the world's most expensive auto-completion. So whatever text you type in, it will gladly predict what the next word is, and the word after that, and the word after that. So it's now a generative process that can actually generate text. And probably it's already pretty good at what you want it to do. If you type in a question, it might already start generating the answer because it's generated text. But it also could just generate more questions because it doesn't know what you want it to do. So you have to then further fine-tune it for the specific task that you want it to. So, for example, if you want it to be a chatbot, then you have to give it a training set of questions and answers to nudge it in a way that it will respond meaningfully to your questions. A newer technique that is now being used a lot is called reinforcement learning, where you have the large language model generate output, and then you have a human provide feedback to the model. Now, this requires far less training examples than if you had started all the way from scratch. So basically, the pre-training is the hard work where it builds up this whole model of human knowledge. And the pre-training is basically to help it understand what it should do with that knowledge. And actually, so there's been a lot of really fascinating and controversial papers like this one, where they had ChatGPT perform or do the United States medical language exam and found that it had a passing grade. I'm not saying by any means that you should replace your doctor with ChatGPT, but I'm just trying to highlight here that it is interesting that these models actually seem to be picking up a lot of important medical knowledge as well, which is what we're trying to leverage here with Keeper. So we evaluated 3 large language models. One requirement that we had was that we wanted all of them to run safely within our organizational firewall. Because even though Keeper output is anonymized patient data, we just didn't feel comfortable sending it over to ChatGPT. So we wanted something we could run ourselves. So the models that we looked at was the Azure OpenAI GPT 3.5 Turbo, which is a commercial product that my employer, Johnson & Johnson, happened to have licensed, so that was available. But I didn't want to just present here on a commercial product, so I also went and got Llama 2, which is a model developed by Meta, which is available free for use for both research and commercial purposes, so I'm calling it open source. And I installed that on a private machine using the Hugging Face library, which is actually pretty awesome. It was just 50 lines of code, and it would download the model, and I could run it on my own machine. As I'll show you later on, Llama 2 wasn't working too well for me, so I went and downloaded whatever was on the top of the Hugging Face leaderboard at the time, which was Sheepdog Llama, which is a further fine-tuning of Llama. Like I said, Llama was made available for any type of use, and these people further fine-tuned it. And I also was just able to download and install that on a private machine. Now, I don't know about you, but I'm pretty new to all of this prompt engineering. So I wanted to have a set of cases that I could just play around with and have around to evaluate different options that I wanted to try in getting the LLMs to actually do what I wanted. So a new set was created using the same 6 conditions that I mentioned earlier. But we didn't randomly sample them. We actually tried to pick the harder cases from those 6 diseases. We only had one reviewer. He reviewed up to between 50 and 100 patients per disease. In total, we had 358 cases reviewed, which I sort of used as a gold standard. And then I computed sensitivity, specificity, and agreement of the LLM with this single reviewer. And again, we used the Optum claims data. All right, so we have our LLMs set up. What do we send them? Well, the prompt itself is just the Keeper output. So this is actually not a very complicated profile, but here you see again the Keeper categories with all of the conditions and et cetera found in each category is just written down as text. So that is the main prompt. But what you usually don't see when you use ChatGPT, there's also something called a system prompt that actually tells the system how to behave in response to your prompt. And so here I use the system prompt to, well, basically what I said is act as a medical doctor reviewing a patient's healthcare data captured during routine clinical care, such as electronic health records and insurance claims. Determine whether the patient had disease, where I would insert the disease that we wanted it to validate. Use the following format, summary, only yes or no. So both system prompt and the main prompt we sent to the LLM, and I just had to write a small parser to get out the yes or no of the answer. And if I did that, then the system would perform with high sensitivity, 99%, but very low specificity, below 9%. Well, if you've done any reading up on what you do in prompt engineering, a very important concept that you come across is called chain of thought prompting. So the way that a LLM, quote unquote, thinks is by generating data. And so if you immediately have it generate the answer that you're looking for, then it hasn't had any chance to think about it. So usually you want it to first basically mull over the problem by having it generate text before actually reaching its final conclusion. So that's what I did. I asked it first to basically list all the evidence in favor of the disease and then all the evidence against the disease, and only then get to the summary. And sure enough, that increased specificity all the way up to 29%. Still not that good. It did drop our sensitivity to 90%. Continuing on this idea of chain of thought prompting, I also asked it to write a medical narrative that fits the recorded health data. And I added that to the output format. That did cause us to take a hit in specificity, but then it restored most of our sensitivity. So I actually felt okay with that because our overall agreement went up. Then I started exploring, well, what is this system doing wrong? And one of the things I noted, well, the system, the LLM is not actually trained to be used for case validation. And one of the things it did wrong is if the diagnosed code was actually in the record of the patient, it just tended to believe that. It's like, yeah, the doctor said the patient has the disease, so he has the disease. Which, if you've done case validation, you know that's not actually always the case. So I provided this very long blob of context for the LLM. Remember that recording a diagnosis for a disease could occur either because the patient had the disease or as justification for performing a diagnostic procedure to determine whether the patient has the disease. A diagnosis by itself or accompanied with only diagnostic procedures may therefore be insufficient evidence, even if recorded more than once. Lack of additional evidence of disease other than the diagnosis and diagnostic procedure probably means that the patient was only being tested and does not actually have disease. However, it is unlikely that the patient will be tested many times over, so as an abundance of diagnoses will mean that the patient has the disease. So I just fed that added that to the system prompt, and as you can see, that actually boosted the specificity all the way up to 31.5%, while costing almost no sensitivity. Well, again, I looked at, well, what is the system doing wrong now? And I noticed that the system didn't actually know how to deal with uncertainty. Sometimes when there were lots of other things that were much more likely, the system would still say, yes, I think the patient has this disease. And other times, if it was very obvious that the patient had the disease, it would come up with some edge case where the patient might not have the disease, and then it said no. And so I tried to explain to the system what it should do in these cases. So I said, I added to the system prompt, in your final summary, indicate yes if the most probable scenario is that the patient had disease. Indicate no if it's not the most probable scenario. For example, when it is more likely that the patient was tested for the disease but the diagnosis was not confirmed. Also indicate no when there is insufficient information to say anything about the relative probability of scenarios. One of the things I think actually is funny about these prompts is that these probably are also instructions you would give to your human reviewer, because they probably need some guidance here as well. Anyway, that did increase specificity quite a lot, up to 58%. It cost us some sensitivity, but again, overall agreement with the human reviewer went up. The last thing I tried is something that's called few-shot prompting, is that I actually provided some example input and output to the system to give it an idea of what I wanted it to do. That did boost the specificity quite a lot, but we took a very heavy hit in sensitivity, reducing the overall agreement, so I actually didn't like that very much. And so my quote-unquote optimal strategy that I ended up with is that one before this, adding the examples. So I did all that using the GPT 3.5 because that was the fastest. So I could very quickly evaluate all these possibilities. I then ran that optimal prompt on Llama 2, which here you see in the second row of this table. You saw that actually you had very poor performance. The reason seemed to be that Llama 2 was just ignoring most of my instructions in my system prompt. But as I said, I went and got a sheepdog llama, which was developed by this company RIAD, which was available on the same license as Llama 2, and that actually did really well. In fact, it did, out of the box, it just did better than the GPT 3.5 Turbo. So I guess an important lesson here is that, so we're not wedded to OpenAI and ChatGPT. There are actually good LLMs available there, even for a research community. But you shouldn't assume that they are good until you've actually tested them or somebody else did it for you. All right, so what does it now look like, the whole system? So here's the example system prompt with all the components that I mentioned earlier. So we don't have to review all of them in detail. We have the prompt itself, which is the output from Keeper, represented as text. And then out comes, in this case, the response by sheepdog llama. With first the clinical narrative, which should look familiar to you because that is actually the narrative that Patrick had you validate. You also see that the system, as instructed, came up with evidence in favor of end-stage renal disease. So there was a diagnosis of chronic kidney disease stage 5 and end-stage renal disease during the visits, but also after the visit. And so in the end, it concluded that, yes, this patient had end-stage renal disease, which is in agreement with all of the human reviewers. So now let's briefly revisit the experiments that Anna showed you. So this is the same plot that Anna showed you for experiment 1, which was using the Columbia data with the 4 diseases. I just added 2 rows and 2 columns for the LLMs. And what you see here is that actually those LLMs and humans agreed pretty much as good. So the LLMs agreed with the humans as much as the humans agreed with the humans, I guess, is what I'm trying to say. So for example, if we look at reviewer 1 using the keeper output, that person had an agreement with reviewer 2 using keeper output of 91%, and the agreement with GPT and sheepdog llama is 89% and 93% respectively. So though not statistically significant, reviewer 1 agreed more with sheepdog llama than with the other human. If we split it up by disease, we see a similar story, and in fact we also see that in this data, reviewer 2 using chart review was the outlier, and he disagreed with basically everybody else, including himself, using keeper outputs, and he equally disagreed with the LLMs. Going to experiment number 2, so same 4 diseases, but now using the Optum claims. The LLMs agreed with humans somewhere between 62 and 82%, which is almost as much as the humans agreed with each other, 72 to 91%. And if we stratify that by disease, one interesting to note here, I'm not sure how statistically significant it is. I'm sorry, I still have to work out those details, but we did see that, for example, GPT 3.5 reviewer 6 was better for COPD than sheepdog llama, but sheepdog llama was better for all the other diseases in terms of agreement with the human reviewers. All right, so but the end goal wasn't to talk about LLMs. The end goal was to compute PPV, positive predictive value. So how do we actually compute that now that we have all these 7 reviewers, 2 of which are LLMs? How do we compute PPV? Well, we can just look at one reviewer at a time. And so then at the bottom, you see the PPV that you would get for any single reviewer. And interestingly enough, that actually ranges all the way from 40% all the way up to 76%. So if you just have one reviewer, you still have a lot of uncertainty about your PPV. Now, of course, if you had 7 reviewers, you would probably combine their data in some way. So if you went to one extreme, you would say if all of them say yes, I do believe it's a case, then you would get a PPV of 32%. If you said if any of them said yes, it's a case, then the PPV is 84%. And if you took the majority vote, it would be 60%. Also note that these confidence intervals are really wide. We only had 25 cases here. I don't think that's enough to actually reliably estimate PPV. So going back to these LLMs and the way that we use them, I guess it all depends on what your preference is and what your thoughts are. If you really don't trust LLMs, which is fair, then you can at least use it as a co-pilot to generate an assessment that a human can then review and adjust, and that will already save you a lot of time. If you've fully bought into our new AI overlords, then you might actually just have the LLM validate your full cohort and use that as your new set of cases and perform the analysis on that. But probably a good middle ground is the one that Patrick talked about, is you use the LLMs to estimate the operating characteristics of the phenotype algorithm and maybe do quantitative bias analysis using that. You can use it to estimate PPV, as I showed you just now, but now I think we finally have a way to also start using case validation to estimate sensitivity. So we tried doing that, trying to estimate sensitivity using an LLM. We followed the suggestion by Stephen Lanes, and we created a highly sensitive cohort for rheumatoid arthritis, which was any diagnosis or symptom or treatment or complication or lab test related to RA. So it's a very wide net, but it's very unlikely that anybody who has RA would be outside of this cohort. We did take a sample of 25,000 because that cohort on Optum was, I think, 2 million people, which even for a large language model is a bit much. So we sampled 25,000 and had the GPT 3.5 adjudicate those. That took 40 hours, cost me $15 that I had to pay to the IT department. I don't know how much my IT department needed to pay Microsoft for that. And now we can use that annotated sample of 25,000 people to actually compute both PPV and sensitivity for a phenotype algorithm. And we used phenotype 196 in the OHDSI phenotype library and established that it has a PPV in this database of 70% and a sensitivity of 79%, which I think that's the first time that we could actually do this, compute sensitivity using case validation. It did require 25,000 cases to be validated. And if you look at those confidence intervals, I don't know about you, but they're okay, but I would actually like them to be narrower. So 25,000 cases validated, and we're not even quite happy with the accuracy of our sensitivity and PPV estimate. So I don't think there's any way you can do this with human reviewers, because like 25,000 cases to validate is just not something that a human would be willing to sit through. And like I said, I probably would do 100,000 next time. So as Anna was suggesting, we could replace the full chart with keeper output. What I guess I'm suggesting is we could also replace the human review with the LLM. That has the advantage that we now have fully automated this process and can then proceed to quantitative bias analysis. So let me wrap up on these large language models. Across all the 3 experiments, the LLMs agreed pretty much as much with humans as humans agreed with humans, which wasn't always not for every disease was very good. LLMs have the potential to increase the scale of case validation without sacrificing reliability, or at least not much. And I think that scaling up is actually a very important thing, because it means, one, you get more precise PPV estimates. And as you saw, without it, you have very wide confidence intervals. And it also now, that's the only thing that would allow you to estimate sensitivity. And that is what you need to fully enable quantitative bias analysis. Now, the performance of these large language models depended strongly on your choice of prompt, as I showed you, and the large language model. I used an approach here called zero-shot prompting, where I didn't actually modify the LLM itself in any way. It already showed good results. You could probably get better results if you actually fine-tuned the model further for this task, but that would require a very large training set, and we just didn't have the resources to do that. Now, I think that we all agree that large language models for clinical care is just currently a bad idea. You don't want ChatGPT to be your doctor. But I think the scenario that we're painting here, where we just use LLMs to increase the reliability of our evidence from observational data, seems both promising and I would say lower risk. So if the LLM really screws up one of these case definitions and gets the answer wrong, that's not going to harm a patient. That at worst is going to mean you have a less accurate estimate of the operating characteristics of your phenotype algorithm. So wrapping up overall, case validation is expected to be part of the evidence generation process to ensure reliability. So I would expect more and more of our OHDSI studies will be doing this. We now showed that we've developed and evaluated at least one standardized set of tools for case validation. We've successfully applied it across multiple data sources. And we did observe that the inter-rater agreement varies by disease, but that was even the case when we did full chart reviews. So I think this points more that some diseases are just harder to validate than others. The results show that the standardized keeper output from the OMOP Common Data Model provides a reliable and more efficient alternative to source records. And that if you combine keeper with LLMs, that allows you to scale this up with similar agreement to human review. Now my final slide. So in the course of this research, we actually had humans review 1,828 cases, which by itself is actually a whopping amount of work. I don't know of any validation study that did that much. So even though the LLMs, of course, completely blew that out of the water by doing an order of magnitude more, I do want to very much say thank you to those human reviewers, Matt, Lauren, Ahmed, Ali, Oleg, I don't know where he is, Vlad, Xiong-In, Anna, and Patrick. So thank you for that. And with that, thank you very much for your attention.
All right, so hopefully we gave you some food for thought, and now we'll give you some food for food. Lunch is outside of the ballroom.